well, let's go ahead and kick things off. John and Peter, I'm so excited about the opportunity to talk about this POCUS webinar today. I think it's something that, yeah, obviously being an anesthesiologist, the topic of POCUS for perioperative medicine is something that's near and dear to me, but it's also an exciting area for people to see the evolution of POCUS, right? If we were having this conversation even 5 years ago, 10 years ago, it would be kind of an off-topic area for the specialty of anesthesiology. And it's so exciting to see that it really is no longer that. And so with that, I'll kick off the topic today on anesthesiologists, the value of point-of-care ultrasound and handheld ultrasound for perioperative medicine. We are joined by a fabulous panel of anesthesiologists here throughout the care continuum here in the United States. I'll let each of you kind of just introduce yourselves and maybe give us a little information on just how you got into the space of ultrasound and why that kind of triggered your interest and how you became an ultrasound enthusiast. And I'll start with Nishant, Nish, if you want to go with that, and then just lead us in.
Thank you. So my name is Nishant Shah. You can call me Nish, no problem. I am a former private practice anesthesiologist as of maybe just 12 to 14 months ago. I did a regional anesthesia fellowship at UC Irvine, which is where I met Davinder. And I'm so happy that we got to be friends because he actually had a lot to teach me about POCUS. And, we kind of talked about regional, and that's where the love of ultrasound came about. I am also the former medical director of a busy orthopedic surgery center, which is part of IBGI, which is the third largest orthopedic organization in the country. And so we were doing nonstop ultrasound-related procedures on all these orthopedic procedures themselves. And so I think when we get into the conversation, I'll have a lot to say about how the ultrasound and the handheld ultrasound and the portability is kind of really an up-and-coming important facet of outpatient anesthesia. Thank you for having me.
Thanks, Nish. I'll switch over to Stephen.
Thanks, Dave, so much for having me. I love the name, the POCUS Power Hour. So I think hopefully we'll give you something powerful to bring back to your colleagues after this nice conversation. So I'm Stephen Haskins. I work at the Hospital for Special Surgery. That's in the Upper East Side of New York. It's an orthopedic hospital, and I actually trained there. I did my regional anesthesia and acute pain fellowship there back in 2013. And just before that, I was introduced to transesophageal echo. The basic perioperative certification had recently come out through the MBE, and I became all about echo, and was super thrilled about the opportunity to learn this tool and bring it into my practice. And lo and behold, next thing you know, I was doing 0 general anesthetics, and so it became a completely irrelevant tool for me. And so I shifted my focus over to transthoracic echo as something that I could use on patients that didn't have an endotracheal tube, and I realized like this was a tool that I could use anywhere in the PACU preoperatively, and that was really sort of my gateway drug into POCUS in general, and got on the FATE bandwagon early on and helped bring that training course over to the US, and that then gave me an opportunity to go over to Denmark and learn long ultrasound and fast and all these other applications. And then next thing you know, I was a POCUS enthusiast. I wasn't just an echo and ultrasound enthusiast. And so, just kind of went from there, helped to, alongside Jan Bublik, who's at Stanford now, who's in NYU at the time, bring POCUS to ASRA, the American Society of Regional Anesthesia and Pain Medicine. Sort of a wonderful opportunity to combine the use of ultrasound largely for procedural purposes and now use it for diagnostic purposes. And there was a huge upswell and enthusiasm for it within the society. And we set up some courses, and then there was a series in publications and so on. And then the ASA finally got wind of it, and now we have a certificate through there that I have helped build alongside Yuriy, who's one of our other panelists. So happy to fill in more blanks at some point, but that's the general trajectory, and excited to talk to you all about the ways in which this can be incorporated into your day-to-day practice.
Thanks, Stephen. Looking forward to diving into all of that. Jody.
Hello, thank you for having me. My name is Jody. I went to UC Irvine for my residency training in anesthesiology, and then I subsequently did my cardiac anesthesia subspecialty training at Cleveland Clinic. Quite frankly, my journey in POCUS is actually because Dr. Davinder Ramsingh, who was my attending at the time at UC Irvine, and he actually designed the course for the whole POCUS session, actually from head to toe. I still remember the POCUS exam on the eyeballs, which I actually don't do as much these days, but I certainly do most of the other POCUS exams on the heart and, the thoracic and the gastric exam. So I think my journey really began with Ramsingh introduced the whole concept of using ultrasound, kind of like auscultation, except you're not really listening and you're really visibly seeing what's happening in front of you. And so I use it actually pretty much on a routine basis. I'm also an associate program director for our residency program at CAC LA General Medical Center. And so certainly POCUS is a big part of our OSCE, and I teach every session. So I not only practice it on a clinical basis, but I definitely also educate our next generation of residents on the techniques, and it is very important. And I look forward to the session of kind of talking about how one can use it in a very relevant way that can guide our management and our treatment. So thank you for having me.
Thanks, Jody. Look forward to getting your insights on education. And one thing about anesthesiologists, you never know when you're going to get out of the operating room, right? And so, Yuriy, I know you're in transit right now, but if you can come off mute and just give a quick introduction, that'd be great.
Yeah, absolutely. Because I'm driving, I'm just going to keep the video camera off until I'm stationary. But first of all,
Please
Dave,
do.
thank you for inviting me to be a part of this wonderful panel. I am an intensivist and anesthesiologist at Duke in Durham, North Carolina. A brief version of my POCUS journey parallels somewhat Stephen's in that I got interested in this space initially through TE during my last year of residency. I did my anesthesia residency and ICU fellowship at MGH over 10 years ago now. And during my last year of anesthesia residency, I decided to pursue the basic TE certification from the NBE. The NBE's pathway is actually a certification. It gave me a foot in the door, the gateway drug, as Stephen put it, to cardiac ultrasound. And then the subsequent year, I did an ICU fellowship. And what happens, I realized during ICU fellowship at nighttime, is that the attendings go away and you kind of have to fend for yourself. And even at a place like MGH that generally is overflowing with resources, at nighttime, you don't get every single diagnostic test that you want with the snap of a finger. And it became obvious to me that if I could figure out how to narrow the differential diagnosis of why my patients were coming to the ICU crashing in the middle of the night, if I could figure out, narrow the list of possible explanations to a manageable few from an infinite initial list of possibilities, it would make my life easier. So I'm all about working smarter, not harder, when I can. And so then I became obsessed with learning transthoracic cardiac ultrasound. And then that year I also got advanced TE certified. When I became an attending at Duke, that was my first job. I then realized that I was still very beginner with my skill set and very unsure of so many things that I came across. So then I decided to pursue every single paper credential available to me in this space, most of which were not for anesthesiologists. In fact, all of them were not for anesthesiologists. For instance, there's a board exam offered by the NBE that's in comprehensive echocardiography that's usually taken by cardiologists after they finish an echocardiology fellowship. So I had observed that other anesthesiologists have actually taken that test and passed it, and I was inspired by their example. Josh Zimmerman is sort of the main person that comes to mind. So I took that test, and then there's a certificate offered by the American College of Chest Physicians, or ACCP, or CHEST is the name for that society. That is targeted toward internal medicine docs and intensivists. So I pursued that, got it. And then along the way, I realized there was really nothing specifically targeting anesthesiologists that would give you a very structured foundation of knowledge in this space. And I had held out hope that the NBE would offer something like that. And what they offered instead in 2019 was another certification that was not specifically for anesthesiologists. In fact, explicitly excluded anesthesiologists, which is the critical care echo boards. So that kind of inspired me to team up with people like Dave, Stephen on this call, and a few other people around the country to petition the ASA and just basically start annoying them to point out the fact that that ASA as a society wasn't doing much to give its members a pathway for learning this material in a structured way, and wasn't giving its members a piece of paper you could take back to your home institution that would back up your credentials in this space. And so that's what we set out to do. And eventually, after a lot of harassing of the ASA, they let us create an ad hoc committee to study this idea. And then eventually the next year, they allowed us to convert that into a standing editorial board, of which Dave and Stephen were inaugural members, and Stephen is now the editor-in-chief of. And that is what allowed us to offer a POCUS certificate. So that was a big origin story of the ASA POCUS certificate, maybe more than anybody wanted to know. But that certificate is sort of like my labor of love, and I have really enjoyed being a part of it, and I'm happy to answer questions. Steve and I or Dave, all three of us have a lot of familiarity with it, if there are some on the call.
Yuriy, thanks so much, and yeah, please drive safe. Peter, good to see you. I'm glad that you're able to join. If you could give a quick intro, and then we'll end it with John. One housekeeping item, just before I forget, because Peter knows sometimes I do. To the audience and please feel free to ask questions throughout the Harvard. So just put it in the chat. The Butterfly team will be monitoring those, and we'll make sure to answer those questions, as many as we can, live during this 1 hour session. But Peter, please.
Hi, everyone. Peter Weimersheimer. I'm an emergency physician. Been doing ultrasound for a long time. Really interesting to hear, that as emergency medicine has had a lot of growing pains of adopting ultrasound in a sane wave to be able to make faster diagnosis and more competent procedures. So hearing the parallel track, and really kudos to the journey that you guys are doing guys and gals are doing to advance ultrasound in your specialty. So really looking forward to hearing more of how that works.
Thanks, Peter. John.
You're muted.
One of my claims to fame is having 25 million dogs in the house, so I stay muted when possible. I'm John Martin. I'm the Chief Medical Officer of Butterfly. I'm a vascular surgeon. I still operate and cause mischief for all of you whenever I get a chance to do so. And candidly, vascular surgeons, I've used ultrasound throughout my entire career, but I didn't necessarily always just use it at the bedside as I do now. But I can tell you throughout my entire career, I've gone from, and I'm old enough to know that an ultrasound wasn't in the operating room at all, to used for central lines and now A lines. But I'm still, candidly, and most of the times I practice with people, I don't see it used routinely for very simple things like gastric volume, bladder volume, cardiac assessment in emergency cases. So I'm really hopeful that what happens in this power hour is that you inspire the heck out of all the rest of the anesthesiologists that are not like you and start using it, because it's an incredibly powerful tool that changes the game in the operating room all the time if you start getting familiar with using it. So I'm really excited that you're here. I'm excited to hear from all of you, and hopefully I'll take these messages and recording back to the anesthesiologists that I practice with on a routine basis.
John, I think that's a great segue, because you're absolutely right? If we talked about the evolution, Peter, you hinted at this, right? The journey of point of care ultrasound for the perioperative space is something that has really only unfolded in the last decade or so. And if you think about, but ultrasound itself, to your point, is something that's been married to anesthesia for 30 years, right? To the point of, using ultrasound for transesophageal echocardiography, then using it for central line and venous access, and then incorporating into regional. Ultrasound for more than 20 years has been a part of it, but it's interesting to see that next step of embracing point of care ultrasound is only relatively new, despite, again, us being very familiar with ultrasound technology. I wonder, and each of you kind of hinted at this, but if you could make a comment on how it started, what particular exam or type or case that presented itself that suddenly was the light bulb moment for you to say, hey, point of care ultrasound, when it comes to a diagnostic tool, what was that trigger point, or what do you think, to John's point about how we can get more engagement, and love to talk about how we are seeing more engagement as well. But if you could comment first on kind of where it started, what examination type was the one that kind of intrigued your kind of interest into POCUS? Stephen, I see you nodding, so maybe you could jump in there.
Yeah, I mean, I alluded to it. I think cardiac is always, that tool that we all get really excited about, and particularly those of us who get training in focused cardiac ultrasound. We have that hypotensive patient in the operating room, and you don't know what's going on. You put the probe on, and all of a sudden, it guides the way in terms of what you want, what you think you should be doing, helps you narrow down your differential diagnosis. But I'll give you a little bit of a twist. Even though cardiac, like I said, was what opened the door to POCUS for me. One of the things that I found really exciting early on when I started learning other skills was the FAST exam, the evaluation of free fluid in the peritoneum, because I work in this unique space in orthopedics where we perform hip arthroscopies on like hundreds of patients every year. We're a high volume center for this particular procedure, and there was this sort of like well-known phenomenon of intra-abdominal fluid extravasation, where fluid would actually track from the hip joint into the peritoneum, in extreme cases cause abdominal compartment syndrome. There are case reports of these young healthy patients dying on the table and they don't know why. I happen to say like, oh, wouldn't it be nice to kind of like do a little study and look at how often this happens, to see how frequently fluid tracks from the hip joint into the abdomen. And we could do that by ordering CT scans on every single patient, or sending them to have full abdominal ultrasound exam done after every single case, or we could just do a fast exam ourselves at the start and the end of each case. And the prevalence is really quite high at an institution like ours, where we have a high volume but also really skilled surgeons. It was in like the 15% range, and I've seen studies since our publication where they repeated it, our sort of approach, and it approached like 30%. That was one of those aha moments where you go like, oh, this thing that's been around for 30, 40 years being used in emergency medicine now has a perioperative application, because I have this skill and I'm thinking about it in a totally different scenario. And that was I think a mind-blowing experience for me when it came to the applications of POCUS.
Stephen, I have to ask, how did you learn the FAST exam at that time?
I actually was invited by Eric Sloth, who's the originator, inventor of the FATE protocol, to come out to Denmark and like get advanced certification, become an instructor. But I attended this emergency medicine lung and EFAST course that sort of was sandwiched between the basic and the advanced, and I was like, oh, this is so much easier than cardiac. Like, it's like fundamentally so straightforward, the sonoanatomy, the interpretation. I was like, how do I not know this? Like, why do I know like all this advanced echocardiography, Doppler calculations, and I don't know how to like look at lung sliding and for like a basic, stripe of fluid, in the in Morrison's pouch. So that was sort of how I got interested.
Thanks, Stephen. Your point there about other modalities and embracing it after learning maybe one sophisticated modality like cardiac ultrasound things. The FAST exam is something that you highlighted the potential value for the perioperative space, but it's still not really mainstream. People don't see and I'm so glad that you gave that use case, right? Because we do have those patients who have unexplained hypotension where you see the value of doing that FAST exam, particularly your surgical type that you just described. That particular surgery is something that you could actually help evaluate on a regular basis, because it's at such a high prevalence of that occurring. I will say one thing, and Peter, I'd love to get your thoughts on this, and we'll go to our other panelists. I have this belief that there's the FAST exam that you have to perform when you're in the emergency medicine room, right? When you are in the ER, that level of skill for you to be able to look and evaluate truly if there's any signs of free fluid can be a fairly sophisticated exam, especially in that patient who's coming in emergency. The value for, to our audience, if you're in the perioperative space, often our question is, do they have like, half a liter or a liter of fluid in their abdomen? And that's why the patient has a blood pressure, that's tanking. That level of fast exam is something that we should all be able to perform and evaluate and assess for. And I bring that out because of the fact that there's subtlety for every type of exam type based on the clinical scenario that you're using it for. And that's the fast exam, I think, is a perfect example of maybe the emergency medicine environment versus the perioperative environment. So, Peter, any thoughts there?
Yeah, I think what's really fascinating about the FAST is the FAST evolved as initially, so the FAST was originally a trauma assessment. So you'd have someone who came in with blunt trauma and who was hypotensive, and it was a quick way to make a decision about what type of interventions could be performed emergently. And that extends to EFAST. You can put a hole in somebody's chest for a dropped lung. You could drain fluid out of a pericardial sac for someone who has pericardial tamponade, or you call anesthesia and surgery and say, go take this person to the OR because they have blood in the belly. And what's fascinating about how the FAST is now really, it has evolved, and this really involves to all specialty, is the concept that it was the first attempt ultrasound to identify causes of shock. So the FAST evolved if you're using the FATE. In the ED, it's the RUSH protocol, but the concept you have a patient in front of you who's unstable, it's just taking an algorithmic approach to find out what are the yes/no piece of information you can get quickly to identify a cause of shock. And really fascinating to hear about abdominal compartment syndrome from hip surgery. Like, who would know? That's something we would see in traumas, but the same protocol of using an ultrasound to systematically go through a patient who's crashing to get that specific answer, and changing management in a way that you might not have even thought about as in your differential initially as you're managing patients. So, FAST was the initial effort at that, and the concept just across specialties, and anesthesia, any type of medical specialty where you're dealing with patients who become unstable, is that you can quickly do hypotension with an algorithmic approach.
Jody, what about you? How did you kind of, and really if you could gear it also towards the audience in sense of where you think they should start, or what do you tell your residents of where they should start on their journey for POCUS?
Well, just listening to everyone, I wanted to agree on, POCUS is very useful for if there are changes in clinical pictures, and certainly, you do your POCUS and you can quickly get an answer and you can change your management. And I agree with that 100%. I actually find that preoperatively, I've actually run into quite a few situations where I am actually making diagnosis preoperatively before taking the patient into the OR, and my diagnosis actually changed the way I deliver anesthesia. For example, I've had a very elderly female who comes in for an ERCP who's looking very frail, and I do my due diligence of doing a physical exam, and lo and behold, I hear a murmur. And for anesthesiologists, if we hear murmur, it's really there. It's not a very soft murmur. So I can't help but wonder what it was, and then I actually listen to my carotid, and I hear some bruit. So then I wonder, wow, what is going on? So I whipped out my POCUS, and I was able to actually diagnose asymptomatic severe aortic stenosis on the spot, and definitely changed my management and how I, ensure her post-operative care. So I think that will be just one of the many examples that I actually find that POCUS has changed my management, not as a rescue exam, but actually as a diagnostic exam preoperatively. And I can give many examples, but I don't want to bore you with too many examples. So that's kind of another utility that I can think of. As far as teaching and education, I tell all my residents, when you learn POCUS, you have to understand during residency, it's an introduction. There's no way for us to actually get you to where you will feel like you are perfect in your technique, because you're not going to be. And it took many years for myself to actually go through the journey of learning and actually doing exams and kind of perfect my technique and feel very comfortable making diagnosis. So the way I teach them is that this is an introduction. It's for you to understand how you are going to move forward, be a self-learner, and decide for yourself that you are going to dedicate and learn these exams and know how to use them. And that's how I approach them. And of course, they have to obviously pass their OSCE exam. So there's some fundamental things that they have to do. So kind of those are my take on my POCUS techniques and how I go about kind of hoping to inspire the residents and next generations of anesthesiologists.
Now, thanks so much for the insights, Jody. And you hit a big topic of preoperative care, right, and assessment. How often, are we more and more the preoperative process is streamlined where less and less people are getting approved for diagnostic tests. I know the Butterfly team is something that we are constantly talking with and figuring out how we can be on the forefront of helping address that, because we know that yes, the people that we wanted to that were getting echoes 10 years ago are no longer getting echoes, right? Recent guidelines are getting more and more stringent on who qualifies for those evaluations. And so now you're trusted to what you can do at the bedside, and the value of hopefully bringing in POCUS there to be able to really help with your preoperative assessment. To your point, you still took care of the patient, but it helped you adjust your way and your mindset of how you were going in to be able to handle the case, and maybe just help risk stratify as well, but maybe even post-operative course too on that patient. So yeah, really exciting journey on talking about the preoperative, and thanks for your insights on education. Nish, I know you and I talked a little bit about the, in your space about, ambulatory surgery centers and the changes there that have happened, and GLP-1s, and just how the patient population has changed. Like any, again, your entry into POCUS, and then maybe if you could highlight a little bit of that topic too.
So thank you for the intro into the topic. And so I'll come at it from a different angle, but to kind of start with the introduction to POCUS, I was force-fed by Davinder POCUS when I met him. I had no choice but to take an interest if I wanted to be his friend. And so as such, I learned a little bit about it. And in the ORs, looking at it from a cardiac standpoint, which you guys have all echoed very well. And so I won't kind of touch on that anymore, because that's really where the crux of it lies. And then the FAST exam, as we spoke about, where it kind of started. But let me take a different angle on this. So when you're in a surgery center or an HOPD, and throughput, egress, efficiency is very important, especially in private practice. Stephen at HSS, I'm sure that that's something that you guys talk about a lot, obviously with all the ortho procedures, and we do it on our end as well. Gastric volume, bladder volume is kind of really important, and on both ends. One, since COVID, you have patients that are without a doubt bigger overall. Now you add GLP-1s into that, and now you have people that, and that actually guidelines are changing all the time. When's the right time to stop it or not stop it? And we won't get into that, but gastric volume is there, right? So you're doing surgeries that might be done under MAC with regional, might be done under LMA, might need to be tubed. And again, you can now look at the spectrum of that and say, hey, this is how the patient looks from a gastric volume standpoint, because we're not going to turn them away. In private practice, to turn a patient away, you really need to have a real reason, right? Or, hey, we're going to switch the order of this, and we're going to make sure that we take care of the patient, but we're going to wait a little bit to make it a little bit more safe and efficacious. On the discharging patient side, you have that really to worry about as well, because you can't keep a patient too long, but you also don't want to hold up things on the other end if you do. So you can look at bladder volume. When you're doing total knees and total hips and we're getting them to walk, and some of the surgeons says, like, we need them to pee, because if we don't, then they may need to be called back. And then you have 30-day bundles, and you have insurance things that we're not taught as residents or as fellows, or even maybe as young attendings, but that are really part of our practice. Is we kind of have to worry about this whole bigger picture. And so something as simple as having an ultrasound that I can determine on the preoperative side gastric volume, on the post-operative side bladder volume, I can decide who to move where and when to move them, whether that's for a case or delay them, whether that's to discharge them or keep them, or how to, do I need to give them something? Do they need more fluid, et cetera? Which again, all goes with perioperative management, both pre, peri, and post. But the point is that something that we never ever thought about is having that little ultrasound with me to be able to, when I bring a patient out, look and see where we are, or when I bring the next patient out, to see where's that previous patient at. And so things that really do help throughput more than people understand. And when you save 10 to 20 to 30 minutes per patient on a given day, that's hours and hours. And unfortunately, the world is based on money. So every minute equals $1. Not that exact conversion rate, but you get what I'm saying.
Yep. No, great insights on again, the value, especially even, something like bladder ultrasound is something that I sometimes often forget to just, you're wondering what's going on, and then you just simply forget to think, oh, I could just pull out this and just quickly look at a bladder volume assessment to see is that's what's really holding this person up, right? In terms of their discomfort level or whether you need to place a Foley and or you're troubleshooting a Foley and things like that. It's a really quick, easy exam to do. You just have to think to do it, which is often the case with POCUS. I think it's something that more and more people just need to think to do it once you feel a little bit comfortable. And Joey, to your point, it's definitely a journey. Yuriy, I know I hate to put you on the last spot here because I know a lot of folks have talked about their intro, but any other thoughts on kind of how you got exposed? And then maybe, I definitely want to start talking a little bit about what's happened amongst the specialty for anesthesiologists and just perioperative providers on the route for certification and how POCUS has been adopted. So if you could maybe start with your entry point, but then kind of talk about a little bit more about that journey of where we are today with, POCUS certification.
Sure. Yeah. There's so many different entry points that I had that I would have a hard time honestly picking one, but in the spirit of what everyone else has done, which is invert your question in some way, I'm going to invert it a little bit and describe a case from today because it's so memorable of a situation. I was working in a remote endoscopy location, an outpatient location here at Duke, where we happen to not have any low frequency probes on within arm's reach, basically. They're not available for unless you go to extraordinary lengths to the main hospital to find it. And I was tasked with taking care of an unusual patient in that the patient had no echocardiograms performed literally anytime within Duke's system or in what we call Care Everywhere, which gives us access to surrounding hospitals, and had a CABG in 2017 and was now completely wheelchair bound. So I had no functional status and I was now coming for an ERCP. And so I was basically forced to take care of him in a way that was ultrasound blind, so to speak, just as most physicians, most anesthesiologists are forced to take care of most of their patients. And so I focused very much on the cardiovascular aspect of things. I just, in the absence of any cardiovascular information about this person, I decided to do a pre-induction arterial line and focused on, keeping him alive through that. And he was very, very fragile from that standpoint. But because I was operating so blind to the cardiovascular side and focused so much on that, I did not pay attention to another aspect of his condition, which was he was coming in with a pancreatic mass and had no real GI symptoms from that except for hiccups. It turned out that when they went in with their scope, they found 4 liters of feculent fluid in his stomach and a gastric outlet obstruction that we were extraordinarily lucky not to face the consequences of as an aspiration event because the patient on his way to sleep didn't feel comfortable being laid flat. So with no knowledge, he had also no abdominal imaging whatsoever. And with no knowledge about his GI tract, we were like within untold micrometers away from having this man endure an unfortunate outcome from aspiration standpoint. And it reminded me that the presence of a low frequency transducer in that same scenario would have resulted in me looking at his heart, having clarity on what exactly is going on there, so I could target my pressors and my whole hemodynamic management of his induction towards that, and then also have the probe available to look at other aspects of his body. And so today's management of him was entirely an ultrasound blind exercise in guesswork, whereas with the benefit of ultrasound, I would have had X-ray vision and, essentially superpowers of diagnostic ability with that ultrasound probe to target my care of him to try to sidestep the landmines that he actually had instead of guessing about the infinite multiverse of possible things that could go wrong. Then to your second question, about how is the ASA POCUS certificate uptake happening nationwide? I think that is what Stephen and I have learned through the ASA is that it continues to be something that is popular for people to enroll in, but very hard for people to complete for a number of reasons. And so the ASA's POCUS editorial board is working on many different ways of addressing those barriers, the biggest of which is helping people to complete the supervised portion of their of their log of studies, which is not that, it's just 5 cardiac exams and 3 each of gastric, lung, and abdominal free fluid. But in many institutions, including private practices, it's hard for people to find a mentor that's willing to sign off on your image acquisition skills. So we have done many things, including increasing the number of workshops at ASA to address that. And each of the ASA Ed Board members is, has been challenged with organizing workshops locally at their areas to try to address that. In terms of how that the certificate is changing patient care, that's really hard to gauge. Just like with any diagnostic test, it's really hard to know whether it's improving patient care or not, outside of, you know, the anecdotes that we all have collected. As we most of us are probably aware, the pulse oximeter has this famous Cochrane meta-analysis that gets updated every 5 to 10 years, where the good people at Cochrane conclude that the pulse oximeter has no value, has no clinical value, has not improved patient outcomes on a meta-analysis level. And so if the pulse oximeter can't meet that standard, it's really hard for any diagnostic test to reach that. But there are situations where all of the panelists have clearly found it useful. And there are pitfalls also, obviously, of misuse of ultrasound that can lead you astray as well. But with that, I'll pause and give it back to you, Dave.
No, thanks, Yuriy, and definitely, Peter, John, feel free to weigh in on this. But I'll do a quick, and for the panelists, let's take this part of, so great to hear about, all the potential use cases, how you were introduced to the value and how it's solidified through different cases, and your journey of seeing how it's gotten you out of being a blind care provider often, right? And, often a common slogan for POCUS is helping you get out of the guessing game, right? Which is often sometimes we're faced with when we are managing patients based on just history and just potential symptoms, when we could actually see what's going on. And it's been interesting, the journey of research showing that over 10 years ago, showing value of, hey, you can, anesthesiologists, this is a relevant topic for all these clinical use cases. This is the research to show potentially why it's valuable in these kind of research environments. And that continued to expand. But to your point, and Stephen, I know you were highly involved with this, society support starting to pick up and seeing the value of, wait, this is not just a niche area for research. This isn't something that we should be adopting and teaching the masses of perioperative providers. And then that getting embraced by, first the American Society of Regional Anesthesia, and then going into ASA. Yuriy already commented a little bit about the certificate program that's happened. Even now, there's ACGME guidelines since 2019, right, for residents to be required to learn basic cardiac pulmonary ultrasound. And Jody, you hinted a little bit about the fact that it's now part of the practicum for your graduation in anesthesiology. So it's really been an evolution to get to this stage. I bring all of that up for our audience because of the fact that I want to comment the fact that, one, for the people in the audience who may not know that, there is that, right? Our residents are now required to learn point of care ultrasound. So this is a new standard for our specialty. So this is not something that's going away. Stephen, I wonder if you could talk just a little bit about kind of that journey of the certification process from American Society of Regional Anesthesia, then going into ASA. And then we did have a question from the panel of, there's a CRNA who asked the question about the ability of them applying and being eligible for ASA POCUS training. So maybe if you could just give a little bit more background, and Yuriy, feel free to jump in, about that, and then to help answer that question.
Yeah, so just again, just sort of how the evolution of the different, I guess, governing bodies have embraced point of care ultrasound, and also speak to the ASA. Yeah, I mean, I think it's been it's been a slow roll, but it's really starting to accelerate. I think part of that is related to the fact that a lot of these societies were essentially designed as subspecialty societies to focus on one particular skill set, and so the cardiovascular and cardiothoracic anesthesia. So they're thinking about the heart, and thinking about the lungs. Regional anesthesia, we're thinking about nerve blocks and pain management procedures. Obstetrics, really just thinking about like management of babies. Pediatrics, thinking about just the management of children. And so I know just from conversations with people who were in leadership early on, when I tried to introduce point of care and FATE to ASRA, they're like, well, we're the American Society of Regional Anesthesia. Why would we be teaching diagnostic ultrasound? Like, we're supposed to be focusing on really just the procedural aspects of this that is outside of the scope of our mission, and does not align with our goals. It really had to be a grassroots ground up Like, we want to learn this. Like, we've heard about this. This is innovative. This is exciting. This is going to help change management. Like, you know, that was what led to the eventual adoption of these skills and creation of courses and embracing things like providing basic FATE certificate as part of the training that you get through American Society of Regional Anesthesia. And I think it was similar. It was people like you, Dave, and Yuriy, who are sort of in the ears of the ASA early on, saying, look at what's happening. There's a lot of interest and energy and enthusiasm. This is happening anyway. You are the largest sort of entity for practicing anesthesiologists in the U.S. You need to take a stance. This isn't just for intensivists. This isn't just for cardiologists. This is for everybody. And I think some leadership are more sort of forward thinking than others. And when you get the ears of the right people, when they're in the right position at the right time, that provides you with the opportunity. And then you have to put, the work and the time in. I think this is as is the case with the sort of growth of technology within any subspecialty. There are a lot of opportunities for advancement and opportunities for pitfalls, and we're in that transitional phase right now that Peter is probably familiar with from a few decades ago in emergency medicine, where like it's getting out there and people are getting their hands on probes and they're super enthusiastic, and there's opportunity to make mistakes and miss things, and that's where we really are pushing for there to be acceptance, by not just the ASA, but the ABA and the ACGME, and to create these sort of meaningful standards and guidelines for education and training. So that way, when you graduate, you kind of know what you're doing. And, for the question regarding, associate providers, CRNAs, AAs, PAs, NPs, you name it. There is a role, certainly, for being able to utilize point-of-care ultrasound in the perioperative setting. Our stance through the ASA is that associate providers should be involved in potentially image acquisition, and that is, we can't be everywhere all the time. But when it comes to the ultimate interpretation and management of that patient, we do think that lies in the hands of the consultant, of the board certified anesthesiologist, and that's ultimately what our ASA certificate is for. It's for the comprehensive indication, acquisition, interpretation, and medical management of that patient. It's designed for physician consultants. And so at this moment, it is not open to associate providers, although we are in discussion about, potentially creating different resources that sort of sit without the physician, the anesthesia physician, or physician anesthesiologist, rather. I hope that answered your question.
It did in spades, Stephen. Thank you so much, and hopefully for our audience, please feel free to ask other additional questions. Again, to give that orientation of where we are. Residents now part of ACGME requirements. There is now a certificate program through the American Society of Anesthesiologists. And to your point, Stephen, Society for CRNAs have been leading POCUS workshops and incorporating this as part of their care pathway for training as well. That gray zone in terms of understanding the interpretation and clinical management is something that's out there and is getting discussed. But to your point about the value, if you're using a stethoscope, one area that I try to, at least my thoughts on this, right? If you're using a stethoscope and making some decisions off your stethoscope, most of the time you should be using an ultrasound too, right? And so the ability to be able to make sure that this technology is available, but within the context of what that range is for that provider is something that we all have to kind of help shepherd and kind of discuss through. Peter, I know you came off mute. Sorry if I talked over you there for a second.
No, I was pushing buttons, but I do, as I'm listening, the journey of having training available and getting not only clinicians but other APPs and other medical professionals in that space to start using ultrasound. And I wonder, what do you say to someone who gets trained, they go back to their institution, and how easy is that for that person to actually start getting privileged, getting support in the institution to actually do the work? Because there's the challenge of having people motivated to learn and offering the opportunity to learn, but then there becomes a challenge, especially for someone who's running with less support in their institution, to become proficient and even to have their practice tolerated by the administration where they are. So I wonder if you can comment on that.
Yeah, just on the bandwidth of how to get penetration and adoption. It's Yuriy, I don't know if you're able to come off mute and talk about that, or Jody.
I think one of the changes I've seen as far as practice, I guess using ultrasound from the CRNA perspective, is I do see them being very proficient at using ultrasound guided IV placement, and I do see that sort of as a very exciting changes that I see in the landscape of our practice at my hospital. So I think it always does take some effort to actually make cultural changes. I think when it is standing on the firm of taking care of patients, for example, a patient with a difficult IV placement, and if you, as the provider, whether you are the MD anesthesiologist or you are the CRNA associate provider, if you're standing on the idea of that this is for patient care, I do see that as a much more advantageous as a way of kind of getting the cultural acceptance of getting POCUS as a technology for other providers other than MD. So I think I can see that as an example of ways of kind of penetrating in a hospital setting. I have not quite seen, obviously, CRNA using POCUS to kind of acquiring images for diagnostic purposes. But I think if IV placement is a start, I can see many years down the road that it can become a more of a common landscape in our practice.
Yeah, thanks, Joe. I mean, definitely a growing area, right, for us to pursue. I think there's a question here on echocardiography, which I know this group is really potentially interested in. But before I jump into that, I kind of wanted to let's segue a little bit into that technology advancement topic, right? About, so we talked about, it's great to know that clinical utility is rapidly growing. The ability to figure out an education pathway and awareness for, the fact that now it's a requirement for new, trainees to adopt this. But how is the technology hopefully improving and then getting us to be able to incorporate this into our care? This is something that I think is an area that is also equally exciting because of the fact that hopefully technology, just like our phone, what we can do with our phone now compared to what we could do 10 years ago, right? Well, actually, for me, it's not much different, but for most people, it's pretty different in terms of what they're able to do with it. And I would say that, if maybe we could take a second to talk about the value of where they've seen the changes in ultrasound technology, in particular, not just for POCUS, but even for regional anesthesia. And, obviously, with the value of potentially more handheld devices becoming of value in the setting as a new modality. Nish, do you have some comments there? I know because of your space and your exposure to some of this.
Thank you. Yeah, I think portability has become a really, really big factor in ultrasounds. I mean, we're used to the big cart ultrasound that's this big and it's got a bunch of buttons. It's kind of like your desktop, if you want to think about it. And then you move from a desktop to a laptop. And now, as Dave's saying, phone. I just got that new Google Pixel Fold phone. So I don't even need an iPad or anything of that nature. I have it on my phone, right? So the portability factor is great. So in the outpatient setting, in the NORA sites, I think the ability to have an ultrasound that has the ability to visualize what we want to, whether it's POCUS or whether it's a needle doing a nerve block, and not sacrificing quality and image acquisition, not sacrificing your ability to localize your needle is huge, because now we can have the best of all the worlds, which is portability, reliability, as well as standard of care not being compromised with your image acquisition, and you feeling comfortable in providing the best care for your patient, whether it's preoperative, perioperative, or postoperative in terms of doing regional, as you just mentioned, because we do them in all different settings at all different times. And when we were doing our pre-talk, someone had mentioned something about AI, and I believe that as we move forward, you're going to think about AI, and you're going to think about things that I think some ultrasounds have, which they can even kind of show you where your needle is, where it needs to go. It can focus on different parts of the needle to help you better acquire the image that you want, so that even when you're maybe not a full expert, not a novice, but somewhere in the middle, you're then able to kind of provide good, efficient, safe care to that patient. And so, not that we got to talk about butterfly example, but that's a portable ultrasound that has the ability to show you that needle at different points and show you the directionality in a way that maybe wasn't thought to be had in portable ultrasounds. And so I think that we have to acknowledge how far we've come from a technology standpoint and the ability it gives us to do what we want, how we want, without sacrificing anything.
Great points, Nish. Thanks. And I think I'll just dive into that one question here about continuous wave Doppler to measure. So the question is, it's really important to have continuous wave Doppler to measure high velocity blood flow in cardiac valves. However, POCUS only has pulse wave Doppler, which may not provide the same level of accuracy. Any comments on this? I definitely have some comments on this in terms of potential value of, while it is true that some handheld devices do not have the ability to have continuous wave Doppler so you can't get that high gradient across, a valve, for example, and be able to get that quantification. But maybe I'll let Jody, if you can just comment a little bit about, well, how would you use a POCUS device in that setting to be able to assess, someone's cardiac function?
Well, I think I tell this to my residents too, is that when you do a POCUS, you're not really, you're not doing, this doesn't sound professional, but you're not doing cardiology level of exam. What you are actually wanting to do is to get enough information to guide your management. For example, the example I gave earlier, when I diagnosed that severe aortic stenosis, I didn't have continuous wave Doppler, but what I had was, I know how bad the valve looked. I know I have a high velocity color flow, and based on those, I already know that it has to be moderate to severe. It cannot be mild to moderate. So that information alone already helped me change my management. So I think I think although there is still limitation with handheld device, but I think I would say majority of the time you will be able to get sufficient information to either make a diagnosis or a rescue imaging to explain why you're facing a clinical change in the picture.
Thanks, Jody. Yuriy, I see your hands up.
Yeah, just echoing Jody. I think, like, in medicine, we have a tendency with a lot of diagnostic tests, including point of care ultrasound, to try to create binaries of normal versus abnormal. And a category that I emphasize to my ICU fellows, to my other trainees, a third category is indeterminate, or image quality not adequate to determine, is a really important third category when you're doing point of care ultrasound, because since you're already doing a limited exam almost by definition, and you have fewer of the bells and whistles that the cardiology sonographers have, as someone pointed out, with the lack of continuous wave Doppler and ultra portable devices, you need to be even more humble in terms of acknowledging when the image quality is not adequate, or when you have an example of an aortic valve that doesn't look like it's completely stuck closed, but it's also not opening widely. That to me is too hard to tell. You don't need to put that square peg into the round hole of normal or severe stenosis. You can say, this is abnormal, but I can't tell how severe it is. And then there are steps you can take from there that are context specific. If you have cardiology services nearby, you could phone a cardiology friend or a cardiac anesthesiologist. If you have better machines available, you can get those. Or you could alternatively, in the absence of that information, just treat the person as though they have severe AS, and proceed with time sensitive cases with extra precautions. So we need not take the imperfect data provided by point of care ultrasound and pretend that it is perfect. We can treat it accordingly. And I think having three categories for almost every diagnosis diagnosis you can make with POCUS is always going to be better than 2 in my experience.
Absolutely, Yuriy. I agree with you 100%. I always tell my residents, if you don't see the structure, please don't comment on it. It just means you don't see it. You just have to say imaging quality is insufficient. I agree as far as answering whether it's severe or not. It really the question you should answer is number one, why are you trying to imaging? And does the image sufficiently answer the question that you have in order to take care of the patient? And I think that's at least from the perspective of an anesthesiologist in a perioperative setting. So I agree with you 100%.
Thanks so much for the comments. Peter, did you have something else there to add?
Yeah, I'll just echo that, this is a bit of diagnostic testing in medicine where sometimes we go accelerate testing based on a perception that we need a certain test or not. And back to the point of the dichotomous versus trichotomous decision, right? We're trying to make a decision on a patient. So and frankly, a lot of folks who are learning ultrasound is on depth and gain. So pulse wave Doppler, all the added bells and whistles, that's more advanced features, but you're trying to make an answer to the patient in front of you. So what information you get is useful. It can be normal, in which case that differential is off the table, at least likely off the table. It can be a positive that you recognize and understand do that information. And then there's that middle ground where maybe not an adequate image, maybe don't have the quite advanced technology up to make that specific answer. That's where you have humility in medicine and make a decision. Can I use what I have to manage a patient, or do I need that other test and phone a friend? And so there's a humility in wanting to get information, being humble about what information you get and how you make a decision from it, and then move forward from there. But not having continuous Doppler, just putting the probe on and seeing a picture and seeing something will add value to the decision whether that next step is needed or not.
Great points. And I think one more question. I think, Nish, you talked a little bit about this, but maybe we're getting close to time, guys. I can't believe, hour goes by quick, and really appreciate all of your insights. But very quickly, Nish, any comments about pain practice and ambulatory care centers on the use of handheld probes? I comment a little bit about that, or again, anybody else who wants to weigh in here, but I will ask for this question and then some final thoughts.
What I would say is that everybody worries about cost. I'm going to speak from the business perspective a little bit more so than from just what the technology is. If the technology is sufficient enough, which we've now kind of passed over that line in the sand, and that everything is really kind of within the same spectrum of quality, then people look at cost, and then people look at how does it help what they're doing, whether it's an outpatient center, whether it's an HOPD, and insurances are forcing more patients to the outpatient center for cost savings, and there's staffing issues, and there's a whole lot of multifactorial things that are going on in the healthcare space, as we all obviously know. But to have something that's portable, that can be moved along a lot more efficiently versus that big cart, is something really that's very, very advantageous and very attractive to many people out there. So I think that once the technological barriers that were there caught up, now the portability really kind of catapults it ahead.
Great insights. So, again, we're almost at the top of the hour. Maybe I'll just ask the panel to go across and just say, very 20 seconds about leaving takeaway remarks to the audience about, again, the journey of POCUS, the evolution of handheld ultrasound, just 30-second little takeaway on, what you'd want our audience to hear. See, Yuriy, you want to start?
Sure. POCUS is something that has helped me take care of patients in the ICU and also in the perioperative environment. I think it's only going to become more interesting as AI is superimposed on the application of POCUS, and image acquisition will remain in the hands of clinicians, but the image interpretation is going to be increasingly augmented, and there may be signal in the data that the AI can recognize that human beings simply would not, that will change how we take care of people. So I think it's an exciting time to at least learn this skill of image acquisition, and in anticipation of getting assistance to augment your skills in the world of image interpretation in the years to come.
Great takeaways. Yeah, the future is definitely very bright for ultrasound imaging. Jody, final thoughts.
I think just kind of sharing the excitement that I look forward to how AI will kind of evolve when it comes to POCUS and ultrasound and handheld device. I think there will be kind of piggyback on what Yuri was saying. I think there will be some advancement in imaging interpretation from AI perspective, and I think I imagine it to be almost like the current EKG, where the technician places the leads and there's an interpretation, and the physician kind of read on top of that. So I'm very excited about the field, and I think it will be an ongoing an excitement for all medicine, really, in all fields. So I look forward to all the changes that will be upcoming soon. Thank you.
Jody. Nish.
I'd like to take a little bit more of a global perspective, and that is to kind of take a step back and realize that not every tool is what you think it is. And an ultrasound was never thought to be what it is that we've all described here and now have at our tip of our hands. And so don't look past something as simple as an ultrasound, because it can provide so much information right at your fingertips, right when you want it, that can help you manage a patient in real time, that can help allow you to do a procedure when you thought that maybe the patient was too difficult to provide an anesthetic to as you normally thought. So I think just kind of keep your eyes wide open, and allow yourself to use the tool in many more ways than it was originally created.
Good thoughts. Stephen, take us to the end.
Well, I think we've alluded to this notion of POCUS being the 21st century stethoscope, right? And I think the key to having that reality, is that we need to have high quality imaging on something that's portable and affordable. And those are the three things that really will get it to the point where we can have that comparison, where we say this is now our stethoscope, and we're getting there. And it's exciting time. Just since Dave, you and I met, the evolution of handheld devices has emerged from these sort of niche things that exist for a few companies to now almost every single one does, and there are some leaders in the field. We happen to be hanging out with them today, who are really pushing the boundaries in terms of what these devices can do, and how many hands you can get them into. Which is really, I think going to be the key element, is allowing people to be able to do this anywhere and everywhere. And so, I think that for me is what's exciting when it comes to point-of-care ultrasound's accessibility, due to, not just the portability, but the affordability of it as well.
Stephen, thank you. And I'll share an incredible thank you to the panelists for taking your time out, sharing your insights, offering your guidance on how you've tackled this important topic for perioperative medicine. We're again past time. We always try to keep it to the hour. But John, I hope if you could just give us one last closing remark here from the butterfly side of things. And again, just one more time, thank you to my colleagues and friends for joining and really sharing your insights.
Well, I really appreciate, first of all, I'd love to clone all you guys and operate with you, because candidly, the expertise that you bring to the operating room changes the game. So kudos to you, and I'm very jealous of the surgeons you get to work with. The second thing I would say is that I'm really hopeful that as this thing moves forward, that everybody gets used to doing gastric ultrasound. There's too many drugs out there today that people are either supposed to stop taking and don't, or you can take the GLPs where MPO after midnight doesn't necessarily mean anything. I've had cases myself canceled because patients didn't stop drugs they were supposed to. I shared with my colleagues here the ultrasound of the stomach, and in both cases we should have gone ahead, but protocol dictated that we couldn't. So, and I think that's a role for ultrasound, and I'd like to see that continue to be addressed across the country. Finally, the last one I will say, as a surgeon, the first ultrasound move I make of all my patients go in the operating room is the bladder ultrasound. I think it's incredibly underutilized, particularly in my population. There's a lot of full bladders that start cases that I think it'd be incredibly helpful if that becomes a routine. And I think my last piece of advice is you should have a handheld ultrasound in every one of your carts. It is every bit as valuable as that Mac 3 blade and the stylettes and all the other things that you have in there. I think this is a tool that should become standard in an anesthesia cart, in a crash cart, and become part of what we routinely do and to assess our patients. And kudos to you guys for actually leading the way, and through your lips to the ears of all the other anesthesiologists in the country, catch up to you guys, because that's where care will get better.
Great closeout, John. And yeah, so just thank you again to the panelists, to our audience. Keep scanning, keep learning, keep embracing it. It's only going to make you a better clinician. And again, thank you so much for everybody for joining, and enjoy the rest of your evening.